So 3 of us are presenting today, myself, Dr. Zachary Regan, who's my partner, and then Dr. Tracy Glinko, who's the current president of the main AGD. We put our credentials there. I'm a master in the AGD, both, and Tracy also. Once Zach stops having kids, he'll finally take his FAGD course, but he has plenty of credits to do it. I gave him by, what, April 15th?
15th, I get an email every morning.
Yeah. And then AFAAID, Associate Fellows in the American Academy of Implant Dentistry. If Nick stops having kids, he'll get his AFAAID. Actually, I got my LLSR this year. I forgot to put that on. I'm still not. Dan has 2 LLSR, Lifelong Learning and Service Recognition Award from the AGD. I put these here just to show we know what we're talking about. We've done dentistry before. Well, this did work.
There it goes.
All right. All right, so here we have some locators. I'm pretty sure everybody's at least seen one of these cases, whether you've done them or not. Maybe that's why you're here today. But I'm going to keep coming back to this particular image just as our focal point. So we're going to talk both about implants, the surgical phase of things, but also the prosthetics. But I do want to spend some time talking about where do you put these? If you're the surgical dentist, where are you going to place these? Rick Crawford, Rick, you want to raise your hand? So Rick's an oral surgeon. Rick's been placing these for years. He and I were just having a conversation regarding how he goes about doing that. I'd love for you to share your technique when we get to that point. What about quantity? So are 2 implants going to survive as much as 4? Are 4 going to survive as much as 6? And then once we get to the maxilla, do those success and survival rates change? Locator selection, so the gold things that you see there. We don't just call locator and say, send me an attachment. There's a process that goes on for you to choose the right selection, both in height, width, and angulation. But also the anatomical considerations. This is a pretty safe place to place implants, but it's not 100% safe. So we're going to talk about that. The intaglio surface of a denture, we've seen this, pink nylon sleeves. We're going to talk about the conversion process, and we have a nice hands-on to go through that process. But we're also going to talk about the quantity. So from an implant or surgical perspective, that's one thing, but also a surgical perspective, there's other considerations with how many of these things do we want to have holding the denture in place. We're going to talk about how to choose the different nylon sleeves. And then lastly, after we're done the hands-on, we're going to talk about best practices and troubleshooting. How many people have ever said, I don't like doing this because it didn't work the way that I wanted it to work? All right. So I'm going to share a quick story that maybe ties into this morning. I plan on getting my hair cut before this presentation this week. Well, that didn't happen. My youngest son's birthday is today, and I had some stuff to do. So I didn't get the haircut. But this morning, I decided to, kind of bring it in right here a little bit. So I started what I thought was going to be an easy process, only to find out, yeah, it doesn't work that way. I haven't cut my hair since I was in college. Well, my wife rescued the day. She at least made it look presentable. So I do apologize with what you see here. But locators are kind of like that. You get going, you're like, God, this is easy. This is paint by number. I should be able to do this, only to find out the patient's back in a week saying it doesn't retain. Dan, you're shaking your head. You've had this happen a few times. So we're going to talk about trouble. Things don't go. This lecture, a year ago, I had sent an advertisement out to do a denture lecture. I got 2 people to sign up. And I even had Wyatt Trena, who's a local prosthodontist, who's an excellent lecturer and an excellent clinician, to do the lecture. And this photo came from that. Apparently, people just don't want removable anymore, but you add implants to it, and all of a sudden, everybody wants to come. So it's kind of an interesting thing to see what people are interested in 2025 when it comes to dental education. The goal is to take fictitious Sally on the left, take her from her not happy face to a patient that's very happy and satisfied. And I think we can all agree implants allow us to get to that point. So quickly, today's itinerary, we're going to spend about an hour and a half talking about the didactics, and then we're going to break away into 3 different groups. Dr. Regan's going to do 45 minutes in the operatories off to the side with Dave Susi. Dave, you here? Dave here? All right, so BioHorizon has sponsored the course. Dave's going to talk a little bit at the end of this morning session. We're going to do a little bit with implant placements. Obviously, this is not an implant placement course. With that said, let's get some reps. If you haven't placed an implant, this is a wonderful opportunity to do a couple. The patients have all consented to it. They're just plastic jaws. So it's a great time to do it. Zach's been placing implants for 10 years. He's completed a maxi course. And Rick, if you want to hang out with Zach, I'd love for you to be part of that conversation and share your wisdom in surgery. Unless you really, really, really want to do a conversion, then you can hang out with me. I'm going to do the conversions in here. We had originally planned on doing it in our conference room upstairs, but Tracy is going to do mini implants. And I'll be honest, mini implants has not been much of my world in implant dentistry. I've always tried to use the narrowest diameter conventional implant I could. I've used them. When Zach took his maxi course, he came back with this, this gusto. Mini implants are great now. They're used for definitive treatment. And I was like, that's not what my educators told me. And then I heard Gordon Christensen saying that you can use them. Everybody knows we can use them for definitive treatment. And Tracy's got a long track record on using them in a definitive manner. So she'll talk about that upstairs. And then we're going to conclude, talk a little bit about occlusion and overdentures, and then lastly, troubleshooting. This is really laggy. All right. Of course, I used AI in generation of this lecture. Zach said I shouldn't put this here. I think it's worthwhile to know, how did AI play a role in what we do? It played a strong role. If you're not using AI, you will someday. But yes, I used it, but I did go through everything. I made sure the science is good behind what I said. So we've all seen this. Anybody know where this picture comes from? Misch, yes. So Misch's textbook. Carl Misch was I still don't even know. Craig, his brother's an oral surgeon, but I think Carl was he a prosthodontist? He was a prosthodontist. Yeah, he passed away a couple of years ago. But he wrote the preeminent textbooks in implant dentistry in the early 90s. And one of the things he decided to do was put some classification behind where do we place these implants. So you might hear me talk about the B and D locations, which are the most common locations for these, or the A and E, the A, C, and E. This is a classification system that we use to articulate where we're going to go ahead and place the implants. This is from his textbook here. He classified not only the locations, but also the restorative things, the prostheses that are going on these appliances. In the world of overdentures, they're classified all the way from OD1, which is your conventional 2-implant locator, to bar overdentures, and they increase based upon the number of implants that you place. And we are going to talk a little bit about bar overdentures. Without a question, that course deserves its own separate time in the sunshine. The problem is they're expensive. Really, when patients are doing two implant overdentures, for most people, they're doing it based on cost. To add a $3,000, $4,000 bar, although the treatment outcome is great, it's just not practical for most people. With that said, when you can do it, it's cool. The thing that I found in my experience, and in any of us who have done implant locators, where the implants go, it's not the B and D location. It's the B and D location, but dependent upon the arch form. So if you're placing the implants, you really want to start the conversation with, what is the shape of the arch? Is it a V-shaped arch, like G in the bottom left, or is it somewhat more square like B? Where the implants are placed is going to differ based upon something we call the anterior cantilever. And to understand the anterior cantilever, we want to talk about AP spread. AP spread, not super relevant in the world of implant overdentures. This concept is really relevant in the world of the fixed all on X or all on 4 concept. AP spread helps define how far behind that upper line and that posterior line, how far you can put the posterior cantilever. But in the world of removable prosthodontics and overdentures, there is an anterior cantilever, or there's a potential for that. So when we're placing implants, we want to have that anterior line be as far forward as possible to decrease that potential cantilever. And to exemplify that, we'll look at this right here. So here we have 2 implants. Anterior cantilever is anything anterior to that. So you can imagine if the patient has a class 2 or edge-to-edge bite, there's a high propensity for a rotation around that axis. The farther posterior though that line goes, the greater the potential moment I'm using that physics term correctly. I hope I am. John, you were like a engineer, right? Am I using that right? Yeah. Retired engineer. Yeah. So these are important considerations. We've all heard the term prosthetically driven treatment planning. That term came out of the implant world, where restorative dentists were tired of trying to save the day because the surgeon placed, nothing against oral surgeons, Rick, and by the way, Rick's implants are always perfectly placed. But the reality is, in the 80s and 90s, when surgeons were just figuring out how to place implants, they placed it where the bone was, not where the restorative interface needed to be. This concept came out, and it rings true to today. So if we think about that potential anterior cantilever, let's place those implants as far forward as we can up to a certain point. We're going to talk about that shortly. Right now. All right. So we have two different arch forms. The upper arch form, if we use the concept of we want to place these as far anterior as we can so that the line is parallel to that anterior ridge, that's about where those implants would go. Form H, we can only go so far until they run into each other. But you could imagine if this used to display over here, if we place the implants over here, say where the canines are, think of the anterior cantilever that would result due to that placement. One might look at that and think that biomechanically, based upon occlusion, that those implants being close to each other would be unstable. But the reality is implants in overdentures are not there to create stability. They're there to create retention. The stability comes from the tissue. So although that looks a little bit too close from a retentive perspective, and from the perspective of getting away from that anterior cantilever, this is favorable. Obviously, keep those implants 3 millimeters apart from each other. Rick and I were talking about a few cases this morning, and probably the most extreme case that I've ever had where I had to place the implants really close on a V-shaped arch was a patient who had her teeth out when she was 13, and she had a 4 millimeter high mandible. And I referred her to an oral surgeon for a subperiosteal. Rick, have you ever done a subperiosteal?
I've only taken them out.
No, taking them out. So they're not really done that much anymore, but I felt it was the right thing to do with a mandible that resorbed. Then I sent them back for a transosteal implant. So we're trying to find these unique solutions. And I just felt bad for the lady because her denture was so unretentive. I literally had to place them right next to each other because that was the only place I could place them in 4 millimeters of bone. What I did is I put a bar. So I had a bar give me that kind of increase and kind of going back a little bit because they were too close. So we have options available to us. But we also have the opportunity to place more than 2 implants. Personally, if I'm placing 2, I'm going to just give the patient 4. I have a hard time, Zach and I agree to this. It's like you're flapping back, you're creating a nice flat ridge, and it literally takes you a little bit of time. Just tack on $1,000 and have 4 implants. Obviously, everybody's going to look at that differently. There's lots of examples in dentistry where it's like, well, I could just do a little more, but that particular procedure costs a lot, so I'm not going to do it. But personally, I feel so much better when I get the patient to 4 or 5, or sometimes even 3. But the point is that where we place implants in the arch is dependent upon arch form. Looking at it from the axial perspective, there's different mandibles. And during my maxi course, I'd say half of my maxi course class, I did mine down in Georgia with the dental school down there, Augusta, Georgia. Yeah.
Dr. Pruitt?
Dr. Pruitt, who's not doing it anymore, unfortunately. Yeah. Long story there, but he was awesome. But I remember half of the class saying, like, I want to place an implant before the next session. You go down once a month for a year. And I remember one of the people saying, like, I feel good. Where should I place my first implant? A lot of people said the lower mandible. If that's the mandible, the answer is, yeah, that's a pretty good area to go ahead and place your first implant. My personal opinion, number 5 and 12 are the easiest places, more often than not, to place your first implant. The point is that you don't know what the mandible is unless you have a CAT scan, or you're really good about laying a flap and seeing what's underneath that. I can't tell you how many cases before I got a CAT scan where I went in thinking I was getting this, and that's what I ended up with. Putting an implant in that site requires a whole different level of surgical skill, flap reflection, ridge reduction, pre-prosthetic planning that you might not be ready for. So if you haven't placed an implant and this is part of your reason for taking this course is to do that. Just be cautious of that. I can't imagine in this day and age if you're going to start placing implants, you don't have a CAT scan, or at least have access to a CAT scan. The lady I talked about, her mandible was like this, and it was about 4 millimeters tall. So in my mind's eye, when I go to place implants in the mandible, my brain thinks that it's upright. And if you've ever placed an implant there, you actually realize that it's much more like this. And if you flap this area, you can appreciate, but even when I flap it, it's still distorted to some degree. Has anybody ever realized that what they see in the mandible is different than what they thought they were going to see? Yeah. Still to this day, yeah. It's just different. So having, whether you're going to do a surgical guide or you're going to flap it back really good. Rick made a very good point this morning that one of the things he does is he appreciates the lingual aspect, because you don't want to go through the lingual. We place an implant like that, that's one thing. But if we're going to place an implant like that, that's a recipe for a potential very bad day. And we don't want the implant to go through that lingual cortical plate. One of the things that I think is valuable, by the way, how many people place implants? So I'd say about half the room. If you place implants, this might be helpful for you. If you haven't yet developed the tactile feel as you're going deeper to feel cortical bone versus cancellous, let's have a conversation. It is the difference between being safe and not safe. You're 10 millimeters into the osteotomy and all of a sudden you meet resistance, that's cortical bone. That might seem obvious, but if you keep pushing in that direction, you're probably going to end up in a bad area. Resistance, when you're past that initial osteotomy depth, is a sign. It's a check engine light saying, go ahead and stop the car right now because something bad could happen. In this area here, Rick, what would happen if that implant went a little too far? Maybe not the implant, probably the osteotomy drill.
I know in my I know I've had some stuff that's through the bone, so we would take post-op panorams, and they look perfect.
They look perfect.
So it's pretty fun though. This probe, whenever you just take a probe and go down your osteotomy and feel it and see if you
Put your finger there.
and just back off.
Yeah. I once took a lecture, I don't remember the guy's name, but he was an oral surgeon who practiced when implants were first coming out. And he said when he first bought a CAT scan and he was imaging his patients for implant placement, but he had already placed implants, he said 80% of his implants were not where he thought they were based on that. So it's interesting. That third dimension is not what we think it is. We have a soft tissue drape that sits over it that makes it difficult for us to know. This image here is nice because it shows us what prosthetically driven treatment planning is. We have a mountain of bone to place the implant. Anybody could do that with their eyes closed if they've never even placed one. But where that implant needs to go, and as it emerges through the cingulum of that tooth, whether that's a crown, screw retained crown, cement retained crown, or a denture, that implant location is very different than what we would do if we just looked at the bone. So what do we do when we run into this situation? Well, we could do a graft. Send it to Rick and he could do a tibial graft, which you probably don't do tibial grafts anymore. Particulate graft with tent screws, block graft from the ramus or the mandible. That's a pretty difficult thing to do, and it's also highly unlikely that you're going to get the width of bone that you need in that area. So if you're going to place your implant, that's what would happen. Well, that's not what we do. We cut off the mandible. We reduce the ridge to get rid of that lower quality cortical bone. When I say low quality cortical bone, I'm talking about the osteogenic potential to interface with that implant over a long period of time. You're better off having the implant in this situation here, something like that. But to do that, you have to lay a pretty big flat. And if you're not comfortable doing this, then it's a good idea not to place implants unless you've ruled out or you've basically made the determination how much width there is at the crest of that implant. From a biological perspective, those implants will probably never give you any issues. As long as the soft tissue as it's sutured back is done well, this is a very stable situation. In great part because there's cancellous bone at this interface here. Implant success is correlated to how much bone you have on the facial of the implant. And Rick made a good point this morning when you place these, place them in this area here. So your comment was, you never see recession in lingual of implants. Matter of fact, one of lingual and palatal. there's a case series in the Journal of Oral Implantology from this summer where these guys were placing implants that were completely exposed in the palate. When I say exposed, outside the bone housing, inside the soft tissue housing, and they had a whole series of these for atrophic ridges. The point is, err on the side of going more towards the lingual because the biology is more favorable in those situations. How many people have ever tried to lay a flap on somebody who's been a dentulist for more than 10 years? Sucks, doesn't it? It's the hardest thing to do. So if you haven't laid flaps, don't let this kind of case for a patient who's been a dentulist for a period of time be your first case. You almost have to use some sort of active dissection in order to get that, because there's so much fibrotic tissue kind of keeping that tissue adherent to the underlying bone. If you want to get into surgery, just lay flaps in the posterior when you extract a tooth. The best way to get better at flap management is to use it to increase your access for simple extractions. So here's what happens when you don't have enough bone or you don't know where you're going. So careful planning and imaging goes a very long way in making sure this doesn't happen to us. So several of us, or many of us, have taken New England Master Track program. You chuckled and you probably just read the first line in the author. Dr. Tim Hempton is a periodontist who's done every single Master Track since 1991, I believe. He's the only lecturer in Master Track who's done every session. And he's famous in my brain for making this comment. If you're doing surgery in an area and you don't know all the important anatomy, you have no business being there. It's extra funny if you know Dr. Hempton, because he's very stoic in his delivery. He's dead serious, but he's also trying to be funny at the same time. So let's take a look at some important anatomy. Obviously, inferior alveolar nerve gives rise to the mental nerve and the incisive canal as we go anterior. The incisive canal is only sensory in its makeup, so there's no motor function to it. Once the teeth are gone, the function of the nerve is gone. There's really no sensory information to the soft tissue in that area. But we're placing implants, especially if we're flattening the ridges, or if there's atrophy to some extent, we're going to place implants in these areas. And for years, I was like, I don't want to place an implant there, but the literature is very, very sparse on its explanation of whether you could do that or not. I've talked to many, many, many people. I've probably talked to Rick about this in years past. The general feeling is that you're safe to do it. But if there was some sort of aberration, you can have a neuropathy result of that. Rick, have you ever seen any issues with that? So
people come back with
the tissue's numb.
you know, you hit something, but it was way in front of
Tom Carella pointing.
And then what we basically tell them is say, hey, you probably have some branches here or there. But I feel really confident that, you know, over the next few months or even 6 months, one day all of a sudden they're going to not even notice it.
So it does happen to enough extent that we should have the conversation with the patient.
Yeah.
I told you I was going to learn something today. Anybody have any comments about this? Obviously, behind the mental foramen is a different story. Lingoforamina, you know, these are some anatomical considerations if you're placing implants in this area. I was trying to get Rick to talk about what would happen if you perforated that and you had a.
Is it going to stop bleeding or is it going to keep bleeding?
See, if that happened to you, you'd just be like, you know, it'd be like if a Toffelmeyer band fell off a tooth to us. But if it happened to us, it's serious. So if you ever get a bleed in this area, this is not something you send the patient home and say, bite down on a tea bag. This is serious.
You know, I'll just bring it up just because tori are hard. But the instrument that's really helped me for tori is a piezo.
We just bought 2 of them, and Zach did his first tori removal with the piezo. And what was your comment? Something like that was the easiest thing I've ever done.
That was so not stressful, you know, because a lot of times when you get deep down in there, I mean, Rick's not panicked. I'm panicked that there's going to be an adverse outcome. And I actually have this PowerPoint that I made for myself every time I repeat before I do anything in an area. I don't go every day of my career. So when I'm going down in this area, I review it, and I always review the action plan for anything that's untoward with the bottom. But with the piezo, I just didn't bat an eye. Zero stress.
Yeah, it's
Much less stressful, I would say.
if you don't have a piezo and you're doing surgery, it's worth the investment. Even extractions, it helps tremendously. Interior loop. I'm sure we all remembered this from dental school. I don't know what the percentage is. My guess is it's probably 25 to 30% of cases, the mental nerve goes anterior to the mental frame and as it loops back. I was taught in my residency and my maxi course, 5 millimeters is the distance you want to stay away from. There are case reports up to 9. So the good news is we have CAT scans. We can see where these are, but just know if you're going to be placing implants close to this area that you want to be conscientious of that. So what's the summary of our anatomical considerations? 1, know your anatomy. 2, imaging in 2025 is the standard of care for safe planning. I don't think anybody's going to argue with that at this point. Consider guided surgery in higher risk cases. Know how to address significant bleeds. So in my residency, I did my residency down in Virginia, and we did this mission trip in the foothills of the Appalachian Mountains. And as a resident, you know, I'm a doctor, but I'm just a 5th-year dentist. I don't really know that much more than the 4th years that are behind me, but my job was to make sure I could bail them out. And then we had 4 oral surgeons and 2 periodontists that kind of backed us up. And one of the oral surgeons had he had like a mobile clinic where he went around the country giving, you know, free dental care. He was retired and he gave away mostly wisdom tooth extractions. And he was working with a 3rd-year dental student who severed the lingual artery. And the surgeon basically just applied pressure and said, go get all the residents. I want them to see how I handle this. Now, I wasn't in the room, but I came in. He says, all right, guys, you ready? And he just let go, and this thing just shot across the room. He's like, he was calm as a cucumber. He applied pressure. He's like, here's how you handle these. And I'm not going to go into that, but if you don't know how to handle bleeds, you know, bigger bleeds and you're doing surgery, it's good to know how to bail yourself out in an emergency where maybe you don't have the time to send it to somebody like Rick. We talked about this. Know how to feel the cortical borders of bone when you're placing implants. Understand what that tactile feel is telling you. Understand that the ideal restorative location and angulation of implants may not be possible due to anatomical considerations. Not surprising, but restoratively driven treatment planning is limited by the anatomy that you have in front of you. All right, back to our picture here. 95% of cases can be easily and successfully planned without much risk to the anatomy. So this is kind of like a summary statement. The point is that 5% of the time, that's not the case, and you should know how to determine which of those are. I wonder if the solar flares are getting in my way here. Dr. Lee, you want to raise your hand? So Dr. Lee works at the dental school. He's a periodontist. He called me. He says, I'm not going unless you talk about soft tissue. At least one slide. All right. It's not surprising. I think in today's day and age, we know that the success of an implant, the long-term success, probably has more to do with the soft tissue, the keratinized soft tissue around the implant than anything else. Evidenced by that case series I was telling you about where these implants are being placed outside the bony housing of the palate in atrophic maxillas, but they're encased by keratinized tissue, but they're not in bone. So I think that's a good kind of positive aspect to this conversation. Down here, we often don't have a lot of keratinized tissue here. If we've ever done this, we've all done that lady who has that flappy little soft tissue ridge and it's a millimeter thick. You're like, I need to place implants here. How am I going to cut that ridge? And you put your 15 blade down and all of a sudden you realize the bone's actually over there. It's not there, and you fall right into the lingual concavity of the situation. Keratinized tissue and management of it is a very challenging part of this process. But if you're doing this kind of dentistry on a younger patient, it's worthwhile giving them the opportunity to upgrade their zone of keratinized tissue. Do you do any grafts across the entire ridge to thicken the zone of keratinized tissue in a edentulous patient that only has a millimeter thick?
Yes.
Yeah. Always. I mean, well, thank you for saying that, because I think it's a good idea, but it's not something I routinely see, in great part because these patients don't necessarily have the funds. But for you to go to the extent to do that, you obviously understand the power of keratinized tissue around implants.
Yeah, also at the same time, sometimes you can see the picture on the top, there's no vestibule. It's very difficult for patient to clean that area. So at the same time, you augment the soft tissue sequence, you also deepen the vestibule. That's also a really important issue.
Beautiful.
That's
Dan.
a great discussion. You talk about 4 implants versus 2 implants and overdentures and bars and things like that. So much time we're dealing with people that have limited funds. So, just like having the ideal bone to put it into, if you go to ICOI, you feel like a failure if you don't graft every site and put it in the perfect position, right?
Yeah.
Same thing with soft tissue. There are a lot of places you go, you feel like, I'm not doing good dentistry at all unless I do full grafts and soft tissue and hard tissue.
Yeah,
So to address that is a big thing.
absolutely. You do any alloderm?
Yes, but usually I don't like to expose the alloderm. If I use alloderm, I want it to be fully covered. Especially use like some older generation of the alloderm, because once it exposed, it can necrose any patient's mouth. Sometimes it smells pretty bad.
Yes.
Yeah.
I find that with resorbable membranes, collagen, at least the previous generation, the cross-link collagen, when those get exposed, it's nasty. Just a single implant, but just showing the power of some version of grafting, whether it's done ahead of time or after the fact. This drastically increases the success of implants. All right, what about the maxillary implants? Most of what we're going to do today, including the hands-on conversion, is going to deal with the maxilla or the mandible, a great part, because that's the most likely scenario that we're going to deal with this. In the maxilla, the challenge that we have, well, let me just start with what are 2 things that are wrong with this picture, or the treatment in this picture? Angle, yep. And the height of the locators. Now, those locators are just way too long. We'll talk about why that is and what to do about it. Well, the problem is in the maxilla, that's kind of where the bone goes. You don't have the opportunity to place them perfectly parallel. I don't know, 90% of the time. I think it's difficult without some sort of grafting procedure to place them perfectly parallel. But what does that mean? So we're going to talk about that.
Need multi-unit.
So multi-unit abutments would be good for, Dom, right? Yeah. So yeah, Dom asked a good question. Multi-unit abutments or angle correcting abutments are definitely something we could do. Primarily, those are used in the world of fixed prosthodontics to help us get a fixed appliance that's on there. But there is a caveat to that. We're going to talk about it. So angle correction, maybe not in the form of multi-unit abutments, but locator abutments that are angled, which we're going to talk about. So what is the minimum and ideal number of implants in the maxilla? I was taught 4 is the minimum, 6 is kind of where you should go, because you lose 1, you're toast after, if you go from 4 to 3, that's a pretty difficult place to be. We bought a practice in Rumford, and if you guys aren't from Maine, Rumford is like, it's just one of the more destitute towns in the state, in great part because the economy has crashed after industry left many years ago. But it was a very flourishing town for many years. There were 7 dentists there once upon a time. A lot of dentistry happened up there, and we come in and we get to see this. So we see all kinds of really wacky things. Partials that have hinges on them. You guys, you probably remember the hinge lock denture. It's like we see hundreds of those. Some of them actually work. But I see a lot of 2 implant overdentures on the maxilla that are there for 25 years and nothing's wrong. Not saying it's a good idea, but I think the conversation should be had. How many implants should you have in the mandible and maxilla? Nobody's going to argue 2 is enough on the mandible. This is a study, it's a meta-analysis or a systematic review looking at the maxilla. The important thing here is when we go from 6 to 4, when they're splinted, the success rate doesn't really change. So what this means, when you splint implants together, either in the version of an all-on-4, all-on-X, some zirconia appliance or hybrid, or you're using a bar overdenture, the force distribution to the implants and the biology that's affected from it do very well. You go from 4 splinted to 4 non-splinted, and the success rate goes down to 88%. That's still good, but You need to educate your patients. Look, there's a drop, there's a higher increase of failure of your implants. I don't know if anybody's ever had to tell a patient that has 4 implants on the maxilla that goes to 3. That's a hard conversation to have, because the conversation isn't you're just going to take the implant out. It's going to take the implant out, and then what? You're going to put another one in. You do a bar at that point. You know, these are difficult conversations to have, especially if you're the one that placed the 4 and it fails a year later. So another study here. By the way, I'm going to share all the PowerPoints. So all the studies that I put, I can appreciate there's a lot of words here. Obviously, this black screen with white text is the recantation of ChatGPT. I love ChatGPT for this purpose. I ask it a question and I say, find me. If you guys ever want to look for science, ask ChatGPT the following. Locate the most recent article in the highest journal impact factor. Journal impact factor is a way, Dr. Lee, you probably know what impact factor is. It's basically like the number of citations that come back to a journal. It's like a popularity contest. So if there's a high impact factor, it just means it's a popular journal. It doesn't mean it's good, but more often than not, it's a good indication. So I say, find me the most recent article or meta-analysis in a journal that has the highest impact factor on the following question that I have. And I get this. 20 years ago, I'd have to go to the dental school and ask them if I go to the library and get out the microfiche, and you know, it's a crazy era that we live in. So I'll share all of this with you guys. Feel free to go through it. The point is that, and I'm going to go right to the summary slide. Take-home message on maxillary overdentures. 4 implants in the maxilla is that's the minimum. There are case reports to say 2. My personal opinion is that should be reserved for very extreme cases where you have good reason to do just that. If you're going to do that, the more anterior, the better. The survival rate is lower compared to mandibular overdentures when they're unsplinted by about 5 to 15%. I think we all probably were taught this in dental school. The survival rate is lower compared to maxillary splinted dentures. So splinting is more favorable, especially in the maxilla. Proper angulation is helpful when they're unsplinted, when the anatomy allows you to do that. Parallelism is likely very contributory in maxillary overdentures, basically saying the same thing. Bone quality. Any of us who have either read Misch's text or taken coursework, he talks about D1, D2, D3, D4 bone. Maxilla is just softer. It's D3, D4 bone. That obviously makes a difference with how much support is there for these implants. Longer implants might help. I am aware that, you know, this conversation comes up. How long does an implant have to be? Misch proved that all of the forces of occlusion on a single implant occurs in the first, 7.5 millimeters of the implant. Why do we want longer implants? Well, if we're going to angle them, that's going to be helpful because his studies did not look at angled implants. In addition, if you have a peri-implantitis case, 7 might become 5, might become 3. So it's nice to have those extra millimeters in those situations. Parafunction is important. Patients who have a history of bruxism are more likely to give you problems with implants and the prosthetics that sit on top of them. And then lastly, in one of the studies I zoomed through, this is pretty important. And anytime I do a lecture, I always learn quite a bit. This is something I learned. Maybe I knew this, but it definitely didn't stick with me, and I definitely don't treatment plan with this in mind. In the maxilla, the success rate is lower when the lower arch is either implant fixed or natural dentition. In other words, a more rigid lower arch, you're more likely to have failure on the upper as a result, as opposed to a lower denture or a lower overdenture.
I'll make a comment on the
Please.
maxillary overdentures, 4 implants, 6, whatever. The most disappointing cases I've had are the
Because it was 4, because they were unsplinted.
because they failed.
Yeah.
They failed way higher than you think.
Sure.
And then you try to bail them out. So you take it out, you can put in another. So if I was going to try to do anything on the maxilla, I would try to make sure that the restorative dentist planned on a bar overdenture.
Yeah.
And I know they're more complicated and stuff, but like when you brought up wire train and stuff like that, if we do something like that, they'll pick a number that it costs. And then if he needs to put in a bar, He'll basically discharge the lap teeth
Yeah.
because he said it's just so important to split them if you can.
Yeah. Yeah. He gave a lecture at the Learn at the Loaf. Was it last year or the year before? He talked a lot about hater clips. He's a hater clip fan.
Yeah.
But the whole lecture was on bars, and he gave that same sentiment. And his comment was, it's easier when you know what you're doing, and the failures are either non-existent or more easily manageable. He's like, the hardest part is just telling the patient the cost of the bar once you learn how to do it. So your point's well taken. And that, once again, I'm glad that you had that experience, but I'm glad your experience aligns with the literature review that I did here.
That's what's fun is the literature finally came out. And in depth, 5 years ago.
Yeah. You should start a journal, the Journal of Rick Crawford. I'd subscribe. All right, lastly, bar overdentures is good. What would a bar overdenture look like with locators? You know, the labs can make these bars and they can incorporate locators into it. What's nice about that is they're perfectly parallel. They're placed where the biomechanics of denture retention is maximized based upon that particular case, not necessarily where these implants are. So you can imagine if that implant there was loaded with a locator, that locator is going to be at an angle. And we'll talk about angulation, what that does long-term. That just wouldn't be as favorable as this situation here. I don't have a lot of experience with metal reinforcement, but we'll talk a little bit about this. But if you ever see a photo that I put here and there's a metal mesh, it's a good idea to have that as a consideration. How many people have started doing 3D printed dentures? Do you find they break a little easier?
Well, that's a question I have for today, in terms of reinforcement of them, and as they come, what can we do to help out the strength?
Yeah, well, we have some slides on that. This is purely anecdotal in my hands, 3D printed dentures, although the concept is absolutely amazing and it will have its place in dentistry if it doesn't already. They shatter.
It's PMMA, it's not.
Yeah, not acrylic. So if you're doing 3D printed dentures, maybe put some reinforcement in, would be my cautionary tale. This, about a year ago, Journal of Oral Implantology, and if you place implants and you don't read the literature, it's a really, really good journal to read if you're into that kind of thing. There was a case study where this guy immediately placed dentures on his implants. In dental school, I was taught, you do that, you're going to go to hell. So forever and ever and ever, I've always considered the patient needs to heal for a period of time. I will say that the literature is starting to show pretty positive signs that we can actually load implants immediately. My gut tells me that if the surgeon is placing it and a prosthodontist is restoring it, your success rate might be one thing, but a general dentist that doesn't have the really refined skills of those two specialists, you're probably not going to get the same results. That's just kind of my subject to change comment. The point is, I would be surprised in the future if we're starting to do more of this. And the literature is really starting to come out that's saying, hey, you can put these overdentures on day one. Anybody do that? Now, this was a retrospective study on 328 implants. And their success rate was, in the ballpark, somewhere around 90%. All right. Any questions about the surgical side of things? Again, this isn't a implant surgery course, but I wanted to kind of give the groundwork that when you as a restorative dentist sees the surgical outcome, you understand what went behind it. Love having some specialists here and some people that have been doing this for a long time. It's very nice to get your feedback. Jonathan.
Could you comment on space, vertical space considerations, going to use a bar?
Yes. Yep. We're going to go over that in the prosthetics. It's a very important conversation. So what Jonathan just asked is restorative space requirements for all of these different appliances. You can't do every option all of the time. It's dependent upon the space. Elijah?
What factor does the depth of implant placement play into the consideration when you're storing a single implant versus a large prosthetic?
How many people place conical implants? I know Rick does, Jonathan, Dan, Mason. So the reason I bring up conical implants, there's a pretty strong trend in implantology for subcrestal placement especially since the conical connection came out. We're going to talk a little bit about the conical connection, what it is, what it means, and why we can place it subcrestal. We're also going to talk about when you place things subcrestal, what happens with the prosthetics. Who's ever placed a healing cap and 2 weeks later the patient comes back and it's loose and you're like, you know, I hand tighten that pretty good. Yeah. Well, it's getting.
I mean, every time you do one, you gotta have your shoulder mills.
Yeah. Well,
Shoulder mills are separate little kits and everything.
bone profiling.
Yeah.
And we have some slides on that. Very, very important concept to understand. And I would make the argument that restorative dentists should do that. Would you agree? Well, if the surgeon doesn't do it, we'll get to that point. I included that as part of the restorative section because it's more of the issue is the restorative components, but it's a surgical thing, surgical aspect. What time we got?